all attendees, or if you're not talking, obviously be on mute. We'll try to answer questions at the end. If you have any specific questions during the presentation, feel free to submit them through the chat feature, and then the rest of our panel will try to work through and respond to your questions during the presentation as they're able. If there's anything that we don't get to during the presentation, we'll just hit them at the end. All of the questions that you've submitted and that we'll be talking about tonight are going to be compiled into an FAQ document, and that will be posted on the ISHA website later this week. A recording of tonight's town hall will also be posted on the website later this week. And finally, if we do run into any technical issues, and if you're disconnected for any reason, don't panic. Just go ahead and you can log in using the same link that you used to get on to this webinar, and we'll pick it back up where we left off. So to introduce our panel here, we have Valerie Brocious, ISHA President, Kim Pritikin, our ISHA VP of Division of Legislative and Regulatory Affairs, Jim Morphew, Legislative Lobbyist for ISHA, Heidi Verticio, she's the ISHA VP-elect for the Division of Legislative and Regulatory Affairs, Kim Wiedoff, ISHA Co-Chair of Early Intervention Committee, Jordan Bowman, ISHA VP for the Division of Professional Services, Roger Reeder, a member of our ISHA's Medical Practice Issues Committee, and Andrea, I'm going to butcher your last name, I'm sorry, but Zwombowski, ISHA Telepractice Committee member. Valerie, why don't you kick it off?
So when we look at telepractice, telemedicine, teletherapy, telehealth, audiology, all of those terms essentially refer to the application of telecommunications technology to the delivery of speech-language pathology and audiology services at a distance. What's important is not what term is employed, but the fact that those services must be of the same caliber as face-to-face services. This is a nice graphic that we actually have permission to use from the Wisconsin Speech Language and Hearing Association. And so when we're looking at what we're going to be discussing this evening, these are some of the main components we'll be touching upon. So let's dive into a scenario in terms of practicing across state lines. I'm an SLP in the healthcare setting who lives in Missouri and holds licensure in Missouri. Due to the pandemic, our current client now resides in Illinois. I do not hold licensure in Illinois. Can I deliver services via telepractice from my home in Missouri to my client in Illinois? Well, we know prior to the pandemic, ISHA requires licensure in terms of the state that you're residing in and also the state that the client is served in. Because of that, the ASLPIC, which is the Audiology Speech Language Pathology Interstate Compact, is designed for member states to alleviate the concern to have multiple licenses if your state has passed the legislation and is a member of the compact. We're not there yet. We have about 8 states that are part of the compact, but everything in terms of the compact has been put on hold. So what's the case scenario? We know in light of the pandemic, Governor Pritzker has relaxed this requirement. If in the instance of a pre-existing relationship, you are allowed to practice across state lines in Illinois without having licensure in Illinois. This is only during the pandemic. Many other governors have also followed suit. So you would need to contact your individual state. But in terms of people practicing in Illinois without a license, it is allowed now during the pandemic. But let's take a look at a CF. I am a CF with a temporary license in Illinois where I've been providing services. Due to COVID-19, I'm now residing in Missouri to be with my family. Can I continue to deliver services via teletherapy from Missouri to my clients in Illinois? This is a slightly different scenario. When we look at a CFY, ISHA recognizes that generally the Missouri Licensing Board would not have jurisdiction over services being delivered in Illinois. However, for a CF, there's a few things to consider. First, the CF would need to check with the licensing board of the state in which they reside. In this case, the state of Missouri does not offer a temporary or a CF license. In addition, looking at the CF's supervisor, the supervisor would need to be licensed in not only the state where services are being delivered, but also the state where the CF is delivering the services from. So in this case, the CF would not be able to deliver services. Let's take a look at some ethical considerations. Concerning client privacy, we know the U.S. Department of Health and Human Services, HHS, has relaxed the requirement to comply with HIPAA. And in this instance, we may now use non-HIPAA compliant platforms without penalty from the Department of Health and Human Services or ISHA's Board of Ethics. However, that being said, we need to be cognizant of the fact that best practices would be to use a HIPAA compliant platform, and we must keep in mind that this will be required post-COVID-19 pandemic. Additionally, in terms of technology, we need to have obtained consent from patients or their family to explain to them the risk of using technology, and then the SLP or audiologist should check with their specific organization to determine if any forms or waivers need to be signed and retained and what that process looks like. If you have any questions, you can contact ISHA's Ethics Committee or ISHA Ethics, and we'll have contact information for ISHA at the close of the presentation this evening. In terms of client abandonment, we know that you have to consider the health and safety of yourself and also of your client. ISHA requires that we hold paramount the health and safety of our clients. However, ISHA also states that no clinician should be required to work in physical danger in order to offer client treatment. In this terms, we need to consider self-quarantine and for at-risk employees, including people that might be pregnant, immunocompromised, over the age of 65, or self-quarantine after a known exposure to COVID-19, or if you're symptomatic. In the instances that you are self-quarantined and you're unable to deliver services, you must create a plan for continued care or continued service. That might be delivering services via teletherapy. It might consist of telephonic services in terms of phone calls. It could be home practice or home program types of activities. You could refer the person to another provider. You could look at interprofessional practice in terms of having another member that's delivering therapy, check in on your patient, look at their orientation or their cognitive status to keep you abreast of changes. These are resources from ISHA. Most of the resources tend to look at some of the HIPAA requirements, but the ISHA telepractice perspectives at the very bottom, those are specifically directed towards teletherapy overall. We've had a number of questions concerning what assessment looks like in terms of telepractice. And so the first two are links in terms of resources. And then in terms of what ISHA has stated, clinicians who deliver telepractice services must possess specialized knowledge and skills, selecting assessments and interventions that are appropriate to the technology and that take into consideration client and disorder variables. Assessment and therapy procedures and materials may need to be modified or adapted to accommodate the lack of physical contact with the client, These modifications should be reflected in the interpretation and the documentation of the service. The documentation piece is very important. We know that some publishers of standardized assessments have developed guidance about administration via telepractice, and others have done some studies that have compared the validity of in-person and remote assessment protocols. And so this is, if you're looking at the data, these are some of the people that you'd want to look at for verification or support from the research. In terms of assessment overall, Pearson does offer resources and assessments that are compatible with online administration. ISHA has the evidence map on telepractice. There are a number of new assessments that are out there. MHS has a new remote administration of the PVAT that does require a headset. If you're looking at an assessment in terms of vocabulary, the instructions are delivered in 5 languages, but it is an English-based assessment as well. I'm not going to go through these, but you might want to carefully look at the information on this and the following slide. It's information provided by Special Interest Group 18, the telepractice coordinator, Jonine Lohman, has shared, and it gives you an overview of some considerations in terms of assessment, and then a few scenarios to help guide you in terms of your practice. And this is the continuation. And now I'd like to turn it over to Kim Pritikin, our Vice President of the Division of Legislative and Regulatory Affairs, and Jim Morphew, our ISHA lobbyist.
Thank you, Valerie. This is Jim Morphew. Good evening, everybody. I'm going to take the first part of this presentation and then turn it over to Kim. I'd like to start by talking about the General Assembly, the state legislature. As you, I'm sure, are aware, there basically hasn't been any activity at all in Springfield. The legislature hasn't met since March 5th. But in the meantime, the House and Senate have established what they call working groups to deal with aspects of the COVID crisis by various subject matters. So the Senate has created 17 working groups, and some of the examples relevant to ISHA are healthcare and human services, licensure, and education. The House has created 14 working groups, and they have similar types of subject matters covered by those working groups. The membership on these working groups is bipartisan, and their goal is to recommend legislation to their legislative leadership that should be considered when the legislature reconvenes. And when that will be is really anybody's guess at this point. Some people that I've spoken to suggest that it will be towards the end of May for a brief session, primarily to deal with the budget. Others are saying that that might not occur until the end of June because the state fiscal year doesn't start until July 1, which is really the ultimate deadline to have a budget in place. But all these other considerations on the stay-at-home orders and the health and safety of all people involved, I'm sure will come into play. And now we're going to talk about some of the executive orders that have been issued by the governor. The first thing that occurred was on March 9th, the governor issued his disaster proclamation declaring all 102 counties in the state of Illinois as a disaster area. This authority is possessed by the governor under the Constitution and under the Emergency Management Act. And basically, it also, and we're going to get into this, this has been challenged in court recently, but this gives the authority to the governor to issue executive orders to suspend statutes, rules, and regulations that compliance with those rules and statutes would be difficult to accomplish during a disaster. As I mentioned, there have been legal challenges filed within the last week, one by a downstate legislator, Representative Darren Bailey, who obtained a temporary restraining order from a judge in Clay County, saying that the governor doesn't have the authority to do anything beyond a 30-day period in which he declares a disaster. So that case has been appealed to the appellate court. Another case was filed today up in the Winnebago County, which is near Rockford, on the same grounds, only the case in Winnebago County is a class action lawsuit, which would cover a much broader spectrum of individuals if it was successful. So of the 29 executive orders that have been issued that are COVID related, there are several that are a particular issue, interest to ISHA, and that's what we're going to cover. So the first is Executive Order 2020-05, which basically closed kindergarten through high school schools for educational purposes through March 30th of 2020. Next was Executive Order 2020-09, which basically deals with telehealth, and it requires insurers that are regulated by the Illinois Department of Insurance to cover telehealth services and reimburse providers at the same rate as in-person visits, and these insurers are prohibited from imposing any cost sharing for in-network providers. Next is 2020-10, which is the first stay-at-home order that was issued by the governor. That required everyone to stay at home until April 7th. And of course, there are exceptions that were built into the executive order. It's a very lengthy document. He outlines what are essential activities, essential government functions, and essential business operations. And those are allowed to continue as normally conducted. However, any non-essential business in operation must cease operations except for what he referred to as minimum basic operations, which are very minimal and are defined in the executive order. And any of those activities that are not essential, employees would be allowed to work from home and continue to conduct their activities from home. And also gatherings of 10 or more people were prohibited. Next is 2020-11, which suspends the requirement that school districts get school board approval to use e-learning. And also there is a public hearing requirement and a requirement that the protocol for e-learning be communicated to teachers, staff, and students 30 days before e-learning is implemented, and those requirements were suspended. Next is 2020-18, which basically extends the stay-at-home order that was issued through April 7th through the end of the month, through tomorrow. And many of the same requirements were kept in place in terms of what's essential, what's not essential, and what those activities might are allowed or not allowed. Next is 2020-19. This provides civil immunity, basically immunity from negligent claims for healthcare professionals, which are defined as licensed healthcare workers who work in healthcare facilities, which is also a defined term. And basically, we're talking about hospitals, SILA facilities, community mental health centers, FQHCs, or any government-operated site providing healthcare facilities established for the purpose of providing COVID-19 related services. So immunity is given to those licensed healthcare workers working in those facilities in a COVID-related function. 2020-31 is the last executive order, to my knowledge, that's been issued. They come in fast and furious. And this provision of particular interest to ISHA, there were several components to it, but it suspends the provisions of the school code requiring 150 clock hours of school-based professional experience for school service personnel, for the school service personnel certificate with a speech language endorsement. So what's coming next? Basically, the governor last Friday, nearly a week ago, announced that he will be filing a new executive order tomorrow that will extend the stay-at-home order until May 30th. Now, he did change some of the restrictions in the order, so he relaxed some provisions that were in the previous order, such as, golf courses will be allowed to open with some pretty severe restrictions. Certain retail establishments that were not essential will be able to provide curbside services, for purchases. Probably the most significant and wide-reaching change is the requirement that face coverings be worn in a public place if the 6-foot social distancing requirement cannot be maintained. Face coverings also have to be worn in public indoor spaces, like if you go to the grocery store. And this will allow schools to establish procedures for pickup of necessary supplies and belongings, and dorm facilities or dorm procedures for moving out of dormitories. And again, all of this is kind of contingent, or at least its long-term effect is contingent upon how the courts will rule on the governor's authority to continue to extend this emergency declaration beyond the first 30-day period. And with that, I'll turn it over to Kim Pritikin.
Hi, everyone. Thanks, Jim. I'm just going to talk a little bit about some of the agencies within the state and nationally that we've been working with to kind of figure all of this out together. Medicaid in Illinois has published rules for telepractice. They are on their website, but I've put two of the biggest ones here. There is an FAQ document for virtual healthcare expansion and their emergency rules, and also their healthcare expansion billing codes, so that if you're going to bill services for those patients, what those codes are, including the modifiers. So those are some really good resources. Additionally, we've been working with the Department of Insurance. They have put out a memo to all health insurance issuers. Additionally, at this time, if you're having difficulty billing insurance, ISHA's resources on reimbursement during this COVID-19 crisis are phenomenal. Please check their website. They are keeping track of insurance companies that are paying and those that are not. Right now, their focus is just kind of on getting the information on who's paying and who's not. And then hopefully it will, once things settle down a little bit, we're going to work on the rate of reimbursement and how much that reimbursement is. We are also have been working with early intervention. Early intervention has been a little bit late to the table in allowing teletherapy or telepractice to begin. They did start that process. Some of the memos are listed here. My recommendation is for people to always check provider connections as well as the DHS website for the most current information. We are currently working with early intervention as well as IDFPR on either a variance or an executive order to allow SLPAs to practice in early intervention. So we're working with them as well. And lastly, the Illinois Department of Financial and Professional Regulation have been phenomenal in working with us for some variances regarding licensure and allowing telepractice, as well as changing the supervision requirements for CFs. And like I said, we're working with them now for the SLPA variance or executive order. And I am going to throw it over to Heidi, who is going to talk about some issues in higher education.
Thanks, Kim. Yep, I'm going to talk about some issues specific to higher education. We're going to start with some guidance from ISHA, and then we'll talk about issues specifically related to us in Illinois. As far as the speech language pathology standards, there has been no change in the required clinical hours. So you can see the breakdown of hours on the screen. Those remain the same. That is to say that 75 hours of the 400 required for speech pathologists can be acquired through simulated patients. Through August 1st, ISHA has approved telepractice and telesupervision as a means for our students to earn clinical hours. Similarly, if you look at the audiology standards, there really isn't a change in those hours either for the students, and the telepractice, telesupervision have also been approved for the audiology profession as well through August 1st. A couple of things to note for these standards is that the short and long-term experiences throughout a student's entire program, that is years 1 through 3, can be used to fulfill the minimum 12-month equivalent of full-time experience. So that may be very important for some of our current fourth years who are out now and unable to go to their location to earn hours. Also, audiology is a little bit different than speech pathology in that any hours that are not completed under a person with their ASHA Cs can essentially be made up after graduation and applied for them to apply for their Cs. Looking at the telepractice with telesupervision then, it is permitted between March 16th and August 1st through ISHA. One thing to note is that 100% of supervision is required for this. Multiple students can be involved in telepractice sessions, and they can earn the full clock hours for those sessions. However, it should be up to the programs to ensure that students are able to meet the required competencies. So it really is at the program's discretion to determine how many students can efficiently participate in those sessions and still earn those hours. Telepractice hours are not the same as simulated hours, and therefore there is no cap on the telepractice hours that can be counted toward the required hours for ISHA certification. If you want to advance, Brian, I think one more now. Sorry. Thank you. Grading requirements, including those grading requirements dealing with pass-fail options, are not determined by ISHA. That is to say, each program is able to define passing requirements. They simply must align with their individual university requirements. In looking at the praxis exam, the administration of these exams has been currently suspended. There is some talk about these exams being converted to a remote option, but nothing is definitive in that area right now. So right now, the main question for graduate programs is to consider whether or not the praxis exam is a graduation requirement. And if it is, programs might need to consider discussing a petition to waive that requirement with their university registrar. And then keeping in mind ISHA certification standards require a passing score no later than 2 years after application. In looking at the telesupervision guidance from the state of Illinois, Kim just mentioned the variance that we worked with IDF PR to obtain. This variance specifically permits telesupervision through July 31st. And what that allows us to do is have a patient, the SLP or audiology provider, and the graduate student in 3 different locations for telesupervision to count for hours. Again, 100% supervision remains the requirement for those sessions. And then finally, Jim had mentioned the Executive Order 2020-31, specifically pertaining to the student teaching and supervised field experience. That has been suspended, and these students will be eligible for a non-renewable short-term approval for that requirement. And now I think I'm going to turn it over to Kim, who's going to jump into some EI.
Thanks so much, Heidi. Yeah, I am going to talk a little bit about some questions that have come about relating to early intervention. So beginning with the roles and responsibility of the service coordinator, and what is that during this COVID period? So the answer to that question is as follows. The big job of the service coordinator right now is to really get in touch with all of the families on their caseload to see if they want to take part in those live video visits. And if they do, it is their job to make sure they get the consent. Right now, we're able to do it off of a verbal consent until we get the written consent, and they send that to directly to the service provider. They also have to make note if the family refuses it as well. The other thing that the service coordinator is doing is coordinating annual IFSPs if in fact that family qualifies for their annual IFSP. And what the service coordinator needs to do is just see if in fact the family does want to have their annual done with a live video visit evaluation. Now the family can opt to wait until they could do a face-to-face service. It is their choice. So that's one of the duties and responsibilities of the service coordinator. And then lastly, the service coordinator is also still doing intake meetings. So they are talking with those families who are inquiring about early intervention. So the next question has to do with the pandemic itself and how we see the pandemic affecting the future of in-home early intervention services when the time comes that we go back into the family's homes. And I think the best answer to that is it's not going to look like it looked in January, and that our new normal is going to be very different. And the big thing is the Department of Human Services is really wanting to make sure that everybody is safe and remains healthy. And that is not just service providers, but the family and the clients as well. And so they're looking to formulate some best practices that they can give us as service providers and families, and they're really going to look at data and stakeholder input. So another big question that has come about is our SLPAs and teletherapy. And the question really is, why aren't our SLPAs allowed to do teletherapy for early intervention, while occupational therapy assistants and physical therapy assistants can provide teletherapy services? And the answer to that question really centers around the Illinois Practice Act, and that the Illinois Practice Act for the speech language pathology assistants states that they do have to be under direct supervision of a licensed speech language pathologist, at least 20% of the assistant's actual client or patient contact time per client and patient on a weekly basis. Additionally, the early intervention program does require SLPAs to be supervised one time a month for every client that they serve. So the issue really is around the telesupervision, because right now, as you have heard, that variance that was issued by the governor is only valid for students and unfortunately not for SLPAs. And when we look at the occupational therapy assistants and physical therapy assistants, their Practice Act doesn't have the same stipulation. Now, it's important to know that ISHA is working with the IDFPR to either get a variance to those weekly requirement or an executive order from the governor. Another question is, will early intervention be extra careful to not throw us back into the homes after shelter in place is lifted? And the Department of Human Services is looking to formulate a group to come up with a plan to have us ready for when that time comes. And I think it's important for everybody to know that they are sensitive to make sure that not only the providers are safe and remain healthy, but also our families that we service. So as I mentioned, they're looking to develop those best practices that we can follow when we do end up going back into the home under what our new normal might be like. The prediction, it's really not going to be like, again, it was in January for some time. The goal, though, is for decisions to be made based on data and our stakeholder input. Another question has to do with initial evaluations, and the question is, do you believe that the EI Bureau will approve initial evaluations via live video visits during the shelter-in-place order? So right now, the only children who are allowed to have initial evaluations are those who have a medical diagnosis or those who fall under the at-risk category. And so they are auto-eligible and they are able to have that initial evaluation so that we can determine the strengths and barriers to help with the development of the IFSP. But all other initial evaluations right now are not being performed via those live video visits. Now, please know that the EI Bureau is working towards addressing this issue in a manner that's going to allow for them to account for the variety of evaluation procedures and practices that occur across Illinois. They just haven't come up with that yet. So the next question is, can we do annual assessments via live video visits? And the answer to that is yes. Those children are already in the system, so they can do annual assessments. The redetermination of eligibility, though, is not required during this period. So these obviously would be done through a live video visit, but it is up to the family if in fact they want this. If they do not want their annual review done via a live video visit, then they can opt to wait until we are allowed to go back into the home for a face-to-face. So ultimately, the family does make the decision on that. So another question is making up services, and is there any way to make up speech minutes once the restrictions are lifted in early intervention? So the answer comes from the Office of Special Education. And when we resume to our new business as normal, then of course we're going to be looking at the client and reassessing the needs and status of the child and the family. And obviously we're going to make those decisions accordingly. So some children, you know, we might need to increase the frequency, duration, and intensity. Some we may not. There's not a black and white answer to the question. It's really based on that individual child and the families that we service. So then the next question is, can service providers make up live video visit sessions? And the answer to this is yes, and all you need to do is follow the Early Intervention Provider Handbook for face-to-face sessions. It's exactly the same. So then another question is, what platform are we allowed to use for live video visits? And one of the things I want to make sure that I say with this slide is I'm not making any recommendations on any type of platforms. But the answer to the question is that early intervention recommends that we use a vetted platform that's HIPAA and FERPA compliant, as that is best practice. The examples that you see on the slide are just examples of vetted platforms. We are responsible to make sure that we don't use any public facing platforms, which you can see on the slide as well. So another question that's come up is, can we order AAC devices from the Illinois Assistive Technology Program during the COVID-19 period? And the answer to that question is yes, but of course some of the procedures have been altered just to reduce the risk of exposure of the virus for our individuals with disabilities. So when they can and when it's appropriate, they will make every attempt to fill these requests. They will make arrangements to either ship them to the customer's home, or if the customer even wants to pick them up, they can, and they are following the CDC's recommendation of social distancing. And so now I am going to pass it on to Andy, and she is a member of our telepractice committee.
Thanks, Kim. I'm going to talk a little bit about school-based issues, and following Kim's lead, we've had a lot of questions around school-based issues, and so I'm going to work to try and answer some of those questions for you tonight. The first question is about licensing for SLPs. And the question we received is, are school-based SLPs subject to the State Department of Education telepractice laws? The answer to that is yes. and those rules are set by the Department of Education. It is best practice to have both the professional educator's license, or the PEL, and your state licensure. And in order to apply online for that PEL, you do need to visit ISHA for that process, but no additional certification or endorsement is going to be required in order to provide telepractice, whether that is in the schools or at a medical or clinic-based setting. Another question we've received is about starting teletherapy. The question is, I've been asked to provide teletherapy to my students for the first time. Where do I begin? The ISHA checklist for school-based professionals that Valerie mentioned in the first couple of slides is a really great place to start. They talk a lot about preparation, environment, the technology and the equipment that you need, some tips for working with parents and caregivers as facilitators. So that would be the first place that I would start, is looking at that checklist. Another recommendation would be to look in Facebook groups. There are a lot of communities that can help you with basic understanding of telepractice, how it works, but obviously not specific to state guidelines. Also, another great place to start is just in general, the ISHA telepractice portal. There are a lot of really great there's a lot of really great information there for you to get started when you're really unfamiliar with telepractice and the guidelines and the policies surrounding it. Another question we received is what technology is required to provide teletherapy services to students? The answer to that is ideally the student and provider will participate from a computer. It really works best in all scenarios to have your student and yourself to be working from a desktop or a laptop computer. Chromebooks and iPads, as well as cell phones, do have significant limitations. Therapists might find that interactivity with resources and materials are lost when either they are using a Chromebook or an iPad, or the student is using a Chromebook or an iPad. And some features that might be available with like a desktop or a laptop version are actually not available if you're providing service from an iPad or a Chromebook. Ideally, the computer should have a microphone and a camera, headsets and earbuds if possible. Again, you really want to try and have a HIPAA compliant platform. That is best practice. You really would like to have a high-speed internet. It's going to be important for you and for your students or your clients to be near the modem or to be hardwired with an Ethernet cable. And one thing to note is that when anyone else in the house is streaming a live meeting or streaming music or videos, you may see some reduced bandwidth speeds. And so it's always best practice to make sure that no one else in the house, if possible, is streaming other types of media. It will reduce your bandwidth. Another question we received is, will I have to provide compensatory services for sessions that were missed due to COVID-19? Right now, the Illinois State Board of Ed urges districts to account for every student who is enrolled. They also recommend that schools and school districts document multiple and varied attempts to contact students, establish remote learning, and to provide FAPE to students. They highly recommend that to document every attempt that you make to try and schedule services, schedule makeup services, is very important during this time. You should know, though, that if a parent does request compensatory services, those services must be completed under the law. If you are asked to do this, it's best practice to refer to your special education director for more details. Another question is about low incidence disabilities. How do I provide teletherapy to my students who have more significant disabilities and can't attend to a computer screen? So in these situations, it will almost liken itself sometimes to a parent coaching model. These students are maybe difficult to engage via teletherapy model, so you really want to work on working directly with that parent to provide home supports for natural communication. In these situations, it's almost really powerful to be able to see the home environment and be able to work directly with that parent to help set up communication supports and opportunities for students to communicate under these natural settings. You're going to want to provide some AAC support and training for those students where it's appropriate, and you're going to want to provide really functional communication activities that involve the family as much as possible and still support the goals that have been written. You're going to focus on simple activities like videos, books, basic communication exchanges, and really functional activities. And these students might require more frequent breaks or smaller sessions spread over time versus longer sessions, and especially group sessions. These students might not be appropriate for a group setting. Speaking of groups, that was another question. Can I provide services to students in groups? How do I ensure confidentiality? The answer to that is yes. The Illinois State Board of Education has mandated that you must have written consent. This is different than some other places and some other states, but in Illinois, written consent is mandatory instead of verbal, and that is really to adhere to the HIPAA and FERPA guidelines. ISHA checklist, if you go to that ISHA checklist that Valerie mentioned earlier, they actually have a sample that you or your district can use for that written informed consent. You also, in order to ensure confidentiality, you want to confirm that your school district has what's called a Business Associates Agreement, or a BAA, to ensure secure encryption of information. And with platforms, you always want to make sure that they're within HIPAA compliance. Another thing you can do is secure your therapy room depending on the platform that you're using. Some platforms will allow you to have passwords, and some will also allow you to lock your room so no one else can come in when they're not supposed to. And that will help if you have students back to back. No other students can jump into your sessions until you let them in. So that's another way to ensure confidentiality. Last question is, do I still have to hold IEP meetings during COVID-19 shutdown? The answer here is that the guidance from the State Board of Ed has said that the IEP team may agree to conduct IEP meetings through alternate means, and that can be teletherapy, phone, any other method. The teams are really encouraged to work collaboratively and creatively to meet IEP timeline requirements for annual reviews, initial evaluations, reevaluations, and any changes in placement. ISBE does state that there is no flexibility concerning a district's responsibility to conduct and develop initial IEPs in a timely fashion. And there's also no flexibility for compliance with federal requirements concerning referrals and evaluations. So at this time, I'd like to turn it over to Jordan to talk a little bit about ISHA issues and ethics.
Awesome, thank you, Andy. Okay, so on to the next slide. All right, so we're going to talk a little bit, well, earlier today, Valerie introduced some of these ISHA ethical considerations and ethical guidance as far as client abandonment and so on. But we're going to talk a little bit more in detail now. So this is the ISHA ethical guidance during natural disasters such as COVID. Clinical relationships may be interrupted if an organization decides to close a program or when a natural disaster occurs. So I think this is really important to point out these two kind of separate things that sometimes also go together. Working in long-term care like myself in either skilled nursing facilities, assisted living, independent living, or maybe in some school systems, an organization themselves might decide or determine to close a program. They could close it anytime and any day because of that natural disaster. In that case, there are a lot of different things that we can do to set up our current patients, clients, or residents that were on our caseload, set them up for success because we are being asked to leave at that time, right? And also there's other considerations when a natural disaster occurs outside of that organization, maybe deciding to close a program. Some things to remember, and this all comes from ISHA, even in the ethical guidelines, Even in these types of situations, practitioners such as ourselves would hold paramount to the welfare of the clients they serve. Every effort should be made to ensure continuity of care and to accommodate the needs of the clients, the patients, the residents. When we cannot guarantee these continued services for that first bullet, those two examples there are acceptable alternative plans that need to and should be pursued. And if you're not talking about, if you're working in, long-term care with older adults or in the hospitals and you haven't quite considered some of these things yet because COVID came in and it's been so crazy, a lot of us are focused on PPE and safety, our safety, our patient safety. These next couple bullets can be very helpful to guide you in your treatment and in your practice. So such plans might involve interprofessional collaboration or team approach to care. This just happened in some centers that I know very well where, the organization decided to close a program. So what can we do as an IPP team or an interdisciplinary team to make sure the patient is set up for everything that they need, whether that's OT, PT, SLP, audiology services, and so on. Developing home programs that could be used during this interim period without all these professional services. I mean, this can go for our students and for our clients, for our patients and residents. I know it's kind of a crazy time, but if we can set them up with different technology, different resources, like things in the community that they can reach out to via phone call or what have you, to make sure that they have some support. Perhaps referring clients to appropriately qualified professionals in the surrounding area in certain times like this, if that's still available. Providing clients and their families with troubleshooting techniques and maintenance activities. I know that Andy and Kim and a lot of us have talked about different ways to set folks up for success if we are doing some either teletherapy or e-visits or things of that nature, making sure that they truly understand how to either use the technology or understand the resources that they have. And what's really important, we do hold our patient care paramount, but these statements do not absolutely prohibit or require any specified activity. The facts and circumstances surrounding any matter of concern will determine whether the activity is ethical. And like Valerie said earlier, no clinician is ever ethically required to work without pay or to place themselves in physical danger in order to offer a client care. So this is just kind of a little bit more details about that ethical guidance during natural disasters. Some things to also think about in regard to prioritizing patient care. So this might also happen in whatever setting that you're working in. A lot of centers are calling it triaging or prioritizing patient care, but there's a lot of adaptations that we've had to make during COVID, and I think we've learned a lot from that. So here's just some guidance specifically from ISHA. ISHA maintains that decisions about patients' care should be made based on the clinicians, our professional judgment, and our clinical expertise. If clinicians such as ourselves are faced with dilemmas of prioritizing patients, decisions should be made. Again, this kind of looks similar to the previous slide, but this is, prioritizing patient care and maybe kind of triaging the specific care that they might need at this time. We would need to use a team approach. As a collective team, whatever that team looks like for you, using a team approach to say who's going to work on what, how can we make sure that the patient gets what they need, the client or the resident, make sure they get what they need when we might not be able to provide all the services like we were able to provide a few weeks, months ago, right? By also seeking guidance, this is extremely important, by also seeking guidance from organization for organization-specific policies, and by also seeking guidance from administrators for facility-specific policies. So we've learned a lot through COVID and typically through other times of either natural disaster or changes in reimbursement and care, that there are a lot of different factors and different people that we need to talk to during this time. Everyone has different policies. So maybe you work for a rehab organization and you have your policies in place. That's your organization. But maybe you work in a center, let's say a skilled nursing facility. That facility has different policies to uphold. A lot of us working in these kind of scenarios, especially with PPE and other different regulations and recommendations, know that they change daily. They change daily, and then that other people might have some guidance for us. This one's really important. I know this is a call for everyone, but there's a very updated specific guidance for nursing homes straight from CMS and CDC. Facilities should maintain a person-centered approach to care. I think we've been talking about that, so that's great. This includes communicating effectively with residents, resident representatives, and/or their family, and understanding their individual needs and goals for care and of care. Facilities experiencing an increased number of respiratory illnesses, and we are seeing this here in Illinois among patients and residents or healthcare personnel, and that's we're also seeing as well, should immediately contact their facility, their organization, their local or state healthcare department for further guidance. When we are in these kinds of times, a lot of times we think we're alone and we don't know who to reach out to. All of you are, those that are on the call tonight, you're here because you need some questions answered. We get a lot of questions too at ISHA. Know that we're here to answer questions. So is ASHA, so is CMS, CDC, your organization and your facility as well. There's also some really nice guidance for documentation of delays, gaps in services. So we see, no matter what kind of setting that you're in, it's like, what about missed visits? What about a gap in service and things of that nature? So again, from ASHA, if there are interruptions to clinical services that delay continued access to care for a variety of reasons, on the slide here, some additional guidance. Review patients' plans of care and consider making any updates or modifications that may be necessary to account for patient access issues related to COVID. So there's a lot of guidance straight from ASHA in regard to COVID for this documentation delay. Communicate with patients and their families to help them understand the situation and assure them that you are doing all that you can to provide or resume services, and ensure that all members of the care team are documenting. This is crucial. We know when we document, we need to tell the story of how things happen and what we expect to see in the future. Make sure you document in the medical record their efforts to adhere to this patient's plan of care, including refuse attempts to see patients in person and all alternative methods used to perform patient visits. I'm going to turn it over to Roger. Thanks, Roger.
Hello, thank you. I'm going to talk briefly about PPE and my experience working in hospitals at this time. Starting to talk about cleaning and disinfecting. Some general guidelines of isolating persons under investigation, PUI, or patients with actual confirmed cases. Different steps we've been taking to remove items from the room, unnecessary furniture, things that do not need to be there, so we can reduce what needs to be cleaned. They've been finding that this virus is relatively easy to kill with basic cleaning products. There's a large list online, 400 items. You can use to look up the code of different cleaning products to make sure that they are something that is confirmed to work against this virus. Some general guidelines of asking people to wear glasses instead of contacts, and making considerations when you're going in, cleaning yourself, going in and leaving work, help reduce the risk of bringing any trace of the virus home with you. I know a lot of practitioners already have practices like this in place from before all of this happening, changing shoes and clothes, coming in and out of work, reducing jewelry, watches that's unnecessary. I know many at my work have stopped using their wrist Fitbit, just as one more thing with all the hand washing that's going on, wiping down your car as you come home, steering wheel, any high touch objects that you come in contact with regularly. Showering before interacting with family and pets when returning home. And of course, like I just said, washing hands regularly. We can go to the next slide. Talking briefly about the at-risk populations for the CDC. I know it was mentioned earlier in the talk tonight, but these are what's currently listed, and it's up to you to monitor your own health and manage your own risk factors. Working as a team in your department and as a facility, make others aware if any of these risks apply to you. so you can make decisions on who may best serve the patient, reducing contact and risk. It's recommended taking temperature twice daily, remaining sensitive to any of your own changes in your health and your own respiratory system. Newly testing is now made available. You can see on the Illinois Department of Public Health COVID-19 website, but now they've announced, testing is now available for people with symptoms, who have risk factors such as contact with somebody who does have a confirmed case, when they've not been using proper PPE when interacting with that person. But testing is also now available for people both with and without symptoms. If they're workers in healthcare, first responders, workers in correctional facilities, and essential workers in public places with frequent public contact, such as public sanitation, restaurants, grocery stores, gas stations, factories, places like that. If we go to the next slide, please. Talk briefly about some PPE. Personal protective equipment, highly recommended at this time, interacting with individuals with confirmed or suspected COVID-19. Make yourself safe first before entering the patient's area. Right now, COVID-19 has been designated as a droplet precaution, and we'll talk a little bit about that on the next slides. But it's at this time we want to make sure we're treating everybody as potentially contagious, keeping a mindset of general universal precautions. This study is obviously, virus is obviously new. We're ongoing study to learn more about this specific novel coronavirus, but we do know from things about previous coronaviruses that we've already had time to study, and we're still learning things about transmission period before symptoms occur, with symptoms obviously, and even transmission from somebody that's not showing any symptoms. Next slide. We have talking about some masks. The governor's going to be asking us to wear a mask in public, but specifically when one-on-one contact with our clients. We're talking about cloth masks. We're thinking like a handkerchief is not rated for protection against standards, splash or spills. Facial masks that we are using should be FDA approved or rated to protect against splash and spills. However, they do not filter air when worn properly, covering the mouth and nose. We're talking about air filtering masks, N95s. You might have heard this term. These are air filtering masks or respirators. They should be used with prior fit testing. If the fit testing is failed, you don't want to assume that the N95 is working for you if it doesn't have a good facial fit. I keep a beard, so that is not an option for me. So I'm going to either lose this beard or switch to some other option like PAPR. There's been questions about what is the N95 respirator mask and how is it different from a general mask you might more typically see. The N95, it designates a 95% efficiency when tested against very small particles, approximately 0.3 microns. So that's basically saying that 95% of that air is being filtered. There's different types of masks that'll have different numbers, but you might see N95 is the most common right now. N95 masks are recommended at this time when working with patients during any aerosolizing procedure. Thinking of things that we work with directly and the hospital with speech therapy, anybody who is on a nebulizer treatment, any patient that's already using high flow nasal cannula, trach placement, open trach tube suctioning, nasopharyngeal suctioning, depending on what your contact is with these types of procedures. This is something that you would want to make sure that you're covering yourself against. Go to the next slide. I'm talking a bit more about masks. They should be discarded when soiled by bodily fluids, when the fit is compromised, or from breathing through a mask after prolonged use, and you notice a change in breathing through that mask, it'd be time to get a new one. We thank our colleagues in our materials management. They're working really hard right now to try to get the PPE out to the staff that needs it at this time. It can be difficult to find. We want to remind people to avoid touching the front of the mask. Again, we're talking about hand hygiene, but the front of the mask is an area where a lot of filtered material can collect. Patients with COVID-19 are not required to wear N95 masks, but it may be a good idea to cover them with a regular surgical style mask, especially when in public or in transit, as long as it's not impairing their breathing. I want to remind patients, healthcare workers that are using masks, especially N95 masks, can lead to buildup of CO2. Prolonged mask use has definitely led to side effects like headaches. Just be sure that you are making time to get into isolated areas, take care of yourself, to take a break from the mask, because it is definitely shown with prolonged use to cause side effects like that. I want to talk on the next slide about different options besides masks. So this is if we're failing a fit test at your place of work, if you had other options for other types of respirators. Here's a picture of a PAPR, or powered air purifying respirators. This is a blow-by machine. Has a battery pack you wear to essentially protect yourself, along with a face mask that's built in. Infection control draws a line between things that travel in air briefly within respiratory droplets and aerosolized things that are actually airborne. Think of hairspray in a small room. When you re-enter the room and you still smell that, that would be something that's aerosolized. Most coronaviruses come from droplets, like a cough or a sneeze, and that's believed to be COVID-19's case as well. More studies are needed at this time, but it's best to take precautions and make the time to make yourself safe and have the appropriate supplies available. Go to the next slide, please. We have face shields, goggles. Eye mucous membranes are also considered another site for infection could occur. So we want to make sure that we're using things like that when generating activity or procedures such as coughing, suctioning, spending face-to-face time with a patient. I'm going to talk briefly, I'm not going to read all of this verbatim, but the appropriate steps to don and doff PPE gear. These are the current guidelines, and these are methods that have been in place before this year, but there's many great video resources that can also be used to demonstrate these techniques. Avoid contamination risk for you and your patients. Be sure to familiarize yourself. Get practice actually putting on and taking off this material before you're asked to do it in a potentially contaminated situation. Make sure you have staff to ask questions to, so that you're ensuring that you're using this properly, especially if there's ever some of this PPE that you aren't familiar with using before. You'll notice during these instructions, hand washing is duplicated purposefully, as they're very important steps. See on the next slide here, to remove PPE gear is also, there's important steps for that as well, making sure that you're not recontaminating yourself after using that PPE to protect yourself in the first place. Okay, here we have IDFPR recently sharing an article by Kristen Ware, American Psychological Association, just about managing grief during this time. Be sure to take care of yourself and those around you. We're dealing with a lot of uncertain times and ambiguous losses, things that we don't know too much about, and that can be scary. There's certain strategies, naming, claiming our grief, talking about what our personal strengths are, aid our coping skills. I want to make a designation to we're maintaining physical distancing right now. But the social connection, needs to remain. If you or anybody needs help, please seek online or phone counseling if needed. There's a lot of employers, HR departments already have access to these services for you, but they can also be found online. Thank you. I'm going to bring it back to Brian.
Thanks, Roger. So that concludes our presentation, and I'll kind of go through a little bit of some housekeeping notes right now just to kind of close this up here. But if you have some individual questions, feel free to continue to go ahead and submit through the chat feature. As mentioned at the beginning of the town hall, we're going to be putting together an FAQ document with all of your questions that were submitted and everything presented in this in the presentation. A recording of this town hall will also be posted on the ISHA website. I'd like to thank our panelists who volunteered their time to put this session together. Their efforts are truly appreciated. My final two slides that I have are actually a list of ISHA committees and their corresponding committee chairs. And ISHA is always looking for volunteers. So if you're interested, feel free to reach out to any of the committee chairs listed, myself, or follow the link at the bottom of this slide, and you can submit a volunteer form. With that, we'll kind of go to the chat to see if there's any remaining questions. I think the main question that's been kind of going back and forth right now is just the whole SLPA issue. And I don't know if Kim or Heidi, I don't know if you want to maybe speak to the entire group about that.
Brian, this is Jim.
Hey, Jim.
Talking about SLPAs and early intervention, essentially.
Yeah, correct. I mean, it's, I think, and you had given me an update at the beginning of this call before everybody got on, but I think maybe just an update to the group might help.
Sure. So as was mentioned during the course of the presentation by several presenters, there has been a lot of discussion, and I think the SLPAs have been contacting both ISHA and the department to seek some relaxation of the statutory requirements to allow them to continue to work. We've been very active working with the department on that, and the issue is the supervision requirements as were laid out previously. And if those requirements were only in a regulation or a rule, the department could easily file a variance like they did with the student supervision requirement. The problem is that the supervision requirement is in the Practice Act, which is a statute which the department itself cannot waive. So that requires an executive order to be issued by the governor, which is a little higher bar than just getting the department to issue a variance or a waiver of a regulation. We've been advised that a draft executive order was submitted by the department to the governor's office, and it was under review by the governor's general counsel. And so we're hopeful that we'll hear something as soon as tomorrow in terms of a particular executive order that would solve the supervision problem and allow the SLPAs to resume working.
Perfect. Thanks, Jim.
Sure.
And then one question that came through, should you provide parents with consent to do telepractice? And any of the panelists can jump in on that one if able.
Can you read that again, Brian?
Yeah, it was, should you provide parents with consent to do telepractice?
Yeah, and I think those were addressed in the beginning slides with that Valerie had presented with the best practice and requirement to do a consent form. I don't remember which one, but I think that was in the first couple slides that Valerie had done.
Gotcha. And one of the intro slides. Perfect. Okay. All right. Well, then that is it, everyone. Like I said, the recording of this session will be posted on the ISHA website soon, along with the FAQ document, and we'll go ahead and send out an email to everyone as well once those documents are posted. But if there's no further questions, thank you and enjoy the rest of your evening, everyone. Thank you.
Thank you, everyone.
Thank you.